bronchioles or bronchi because there hasn't been enough surface area to catch dust by that. The lungs are bronchial tree plus alveoli plus connective tissue holding it all together.
Did you skip a slide? Or did you take one out?
I think I did. You could just cross it off. I didn't reorganize it. I just took
Okay.
some things out. So there's a spot called the hilum. I don't think we've used this word yet. We're going to use it again with the kidneys. When an organ has a spot where multiple tubes connect, all clustered together. Oh, I think we used it on the liver. Yeah. That's called a hilum. What connects here is the first bronchus for each lung and the pulmonary arteries and veins. So all the branching out is going to come from there. And I've over-exaggerated the size of the hilum just to show the tubes more clearly. Covering the lung is the pleura, the serous membrane. You've got a visceral pleura that's against the lungs, surrounds each lobe, and then the parietal pleura that lines the thoracic cavity, so it goes against the diaphragm, the inside of the ribs, and some muscles. Each lung is divided into lobes. Fissures are the dividing lines between the lobes. Do the left also. It'd be something like this. Right lung has 3 lobes, left has 2. Why would the left lung be smaller? We already said what's between the lungs.
The heart is the
Heart.
bigger part.
Yep, and the heart's just a little bit off to the left. Now, if you remember your anatomical terms, you can probably guess the names of the lobes on the left, superior and inferior. We need a third on the right, and so we just copped out and called it the middle lobe. First branching of the bronchi comes out to, you've got one for the lung, and then the next ones is one for each lobe. And after that, they go smaller to spread out within the lobe. Here's, they've only included the bronchi on the right side. That's the one for the superior lobe, this one for the middle, and this one for inferior. Now from the front, it looks like the inferior lobe is really tiny, but if you, this angle that you see continues, and so toward the back, the inferior lobe is the largest and the superior is smallest. So they're just unevenly aligned.
If you look at them, they look like they're the same size.
The 2 lungs?
Yeah.
Yeah, it's this spot here that's the difference. It's actually kind of a little bit hollowed out where the heart, where it hooks around the heart. So yeah, here, top to bottom, side to side, they're about the same size. There's just a little bit less on the left. And then this is another view of some alveoli. Questions on lungs?
I wonder if it would ever be possible to have a lung transplant.
I think so, yeah. Because you would only have to connect things at the hilum. And then,
So where does the hilum connect here?
it is, you can just barely see where this bronchus is coming in. So the arteries and veins would connect there too, so it's about like that. It looks like it's in the superior lobe, but because of the way they angle up, they're actually all meeting right there at the hilum. Other lung questions? Next section is on how we do ventilation. We usually refer to inspiration is breathing in, what we often call inhaling, and then expiration or exhaling is breathing out. So you got in and ex like exit. They work by changes in pressure. And the pressure is based on volume. So this uninflated balloon is really easy to squish and bend. There's a small volume of gas trying to take that up. Or there's a small amount of gas in there. Now, gases will fill whatever volume you give them. Now, I've inflated this a little bit, and it's fairly easy to squish. The gas pushes against the walls of whatever it's in. If you try to squeeze more gas into the same area, or squeeze the same amount of gas into a smaller area, like if I squish this and then try to push on spots, it's harder to do. Basically, for a particular amount of gas, its pressure and volume are what's called inversely proportional. If one increases, the other one's going to decrease. When we looked at blood pressure, most of the factors were directly proportional. If one increases, then the blood pressure increases. The one that was inverse was the vessel diameter. A larger diameter means lower pressure. And that's a similar concept where if you have a larger space, the stuff in it is reduced in pressure. And that's going to lead us into why the air moves in and out of the lungs. Does that make sense so far? The air in this balloon is under some pressure because the balloon itself is trying to shrink back down because it's elastic. So if I allow it, the air will push out to where there's less pressure. So in order to inhale, what we do is enlarge the lungs because that will decrease their pressure. And the air around us will force its way in to where the pressure is lower. So the main muscle we use is the diaphragm, which is curved. It's kind of a dome shape. When it contracts, it pulls down. That's going to expand the thoracic cavity also. And then because of the pleura with the serous fluid, as you expand the thoracic cavity, the lung sticks to it and also stretches. It's like if you've ever put away a glass that was wet and stacked them together and then it's hard to get them apart. That's what the pleural fluid is doing. When we increase the volume of the lungs, that decreases the pressure. Takes it a little below atmospheric pressure, the pressure all around us, and so that air pushes its way in. And that's inspiration. Contract the diaphragm, that expands the lungs downward. There's also some muscles between the ribs that lift the ribs. And if you look at these numbers, not that I'm going to ask you to remember them, you see it's not a very big difference, just about 2 millimeters of mercury, which is the same unit we use for blood pressure. But it's enough for the air to move. And this is why it can be harder to breathe at higher elevation, because the atmospheric pressure is lower. So you have to expand your lungs more to make a difference. For expiration, we don't need to use any muscles to squeeze the thoracic cavity smaller. We just need to relax the diaphragm and it'll lengthen back out, which causes it to dome up again. the lungs are stretchy, and just as this balloon shrank back down as soon as I let it, that's what your lungs will do. We call that elastic recoil. As soon as we stop stretching the lungs, they shrink back down. That increases the pressure and the air moves out. Okay. Now, the accent in this video is kind of cheesy, but it was the best one I could find for the visuals.
If you write anything on your computer, you need to get grounded.
I write pretty much all day.
Breathing movements. Inspiration. The pressure in the lungs is decreased and the air rushes in. The muscles of the diaphragm contract to make it descend. The rib cage moves upwards and outwards. Expiration. The pressure in lungs is increased and the air is pushed out. The diaphragm becomes dome-shaped, relaxes and moves up. Simultaneously, the rib cage moves down and in.
Questions on ventilation? I've seen people look at the clock. Do we need a break? We are going to go over regular lecture time. That's because we did the lab exam first and that's lab time. So we can also measure the amount of air that we're inhaling and exhaling, and that's called spirometry, which just means measuring air. There's a bunch of volumes that can get measured if you want to learn a lot about somebody's lung function. The major things are tidal volume is just the amount in your breath when you're not thinking about it. Reserve volumes, you know how you take in an extra deeper breath or exhale some extra, those are called reserve volumes. Space that's in your lungs that you could use if you need to, but most of the time you don't. When you put those together, you get vital capacity, which is the largest breath you can possibly take. So, say you've been running and you're really fighting for breath, you're probably using most of your vital capacity. Questions on the measurements? I forget if I still had total lung capacity on the study guide. If I did, that's all the air that fits in your lungs. There's a little bit that's not inhaled and exhaled because you've got airways held open with cartilage that can't just shrink down, so you can't get all the air out. Some clinical stuff. Emphysema is a form of COPD, which is chronic obstructive pulmonary disease. Chronic bronchitis is also a form of COPD. Somebody might have both or just one. What happens in emphysema is losing walls of alveoli. They combine together. You had a cluster of them, they were probably something like this. If you lose some of those walls, you get bigger spaces with less surface area. And the surface area is where you do the gas exchange. So with losing those walls, it makes it harder to get the oxygen in and the CO2 out of the blood. This also includes losing the elastic recoil of the lungs. So they don't shrink down as easily when you stop stretching them with your muscles. And that can make it difficult to exhale. had those, we had slides of emphysema in the lab. If you didn't look at them, all I had to do was hold it up to a light and I could see how much more open space there was compared to the regular lung.
Did you say influenza?
No, emphysema.
Oh, I was like,
With influenza, you get inflammation and extra mucus and stuff as you're trying to fight off the virus. All right, lung cancer, in some cases it starts in the lungs, in others it can spread from cancer in other places. The most common location is that it's actually forming in the walls of the bronchioles, the smallest tubes. The tumor can block the airflow and the gas exchange. Lung cancer is one of the worst ones for survival rate.